Yes, definitely. That's one of the major concerns that we have from an oncology perspective, is that we can only control what we can control. The price of the drug we can't control. We can't control inpatient stays or anything that's not related to oncology. And with the OCM, sometimes, if the patient goes in for a hip replacement, if the patient has a heart attack, you get that. There's parts that come in and out. There's the level of scale and some other things that they're doing, but you get the total cost of care, which doesn't always include only oncology. So we've really been looking at models, and I know there's a lot of models out there with COA and even with the Mason grant through PTAC that says, let's take the cost of drug out of it. Let's look at a way so that we're not responsible for things we can't control. Let's emphasize the things we can control. The patients calling in and keeping them out of the ED and having urgent care visits and same-day visits and managing that patient's symptoms and their treatment so that they don't end up in the ED, so they don't end up in the inpatient unit unless they absolutely need to be there. And some of them need to be there. There are those cases where the patient should be in the hospital, and we need to not keep them out of the hospital because we're worried about cost.